For any medical trainee, the pancreas can feel like a total black box, right? Well, today we're going to crack it open. We're breaking down the key ASGE guidelines on the role of endoscopy in benign pancreatic disease.
The thing about the pancreas is that it's notoriously complex. So when something goes wrong, it can be a real diagnostic challenge. You need a system, and you absolutely need the right tools for the job.
And to navigate this, we really have two main endoscopic tools. Think of endoscopic ultrasound, or EUS, as your investigator, your detective. It gives us these incredible high-resolution images and lets us get tissue samples. Then you've got ERCP, which is the interventionist. That's the tool that lets us get inside the ducts to actually fix things. Knowing when to use which one is absolutely critical. All right, let's start with a classic scenario you'll see all the time. A patient comes in with acute pancreatitis, but all the initial tests, the labs, the CT scan, they all come back normal. We're left scratching our heads with an idiopathic case.
And this isn't some rare thing. After you do the whole standard workup, a whopping 20%, that's 1 in 5 cases of acute pancreatitis, gets labeled idiopathic, which just means we don't know what caused it.
So as a trainee, this is where you're at a crossroads. Do we just stop the workup and say, we don't know? Or do we dig a little deeper for our patient? Well, the guidelines give us a really clear path forward.
The answer, it turns out, is EOUS. The guidelines strongly suggest this is the next powerful step. And get this, in almost a third of these so-called idiopathic cases, EUS can actually find the hidden culprit that all the other imaging missed.
And this slide really shows you what EUS is looking for. Its resolution is so good it can spot tiny little bile duct stones, or even just biliary sludge that a CT would never see. It can also pick up subtle signs of chronic pancreatitis. And, maybe most importantly, in patients over 40, it's excellent for making sure there isn't a hidden tumor causing the problem.
So here's the take-home principle, the thing to burn into your memory. Diagnose with the less invasive tool EUS and save the higher-risk ERCP for when you've actually found something that needs fixing, like a stone that you have to pull out.
Okay, let's switch gears to our next topic, autoimmune pancreatitis, or AIP. This one poses a very different and, frankly, a very serious diagnostic challenge. The main problem here isn't just finding a cause. It's being absolutely sure you're not missing a cancer. You see, AIP is a great mimicker. It can create a mass or a blockage that looks terrifyingly similar to pancreatic cancer on a CT or MRI.
Now, this is a really subtle but super important point. A standard EUS with a fine needle aspiration, or FNA, is fantastic for getting some cells to prove there's no cancer. But those cytology samples, just the cells alone, often aren't enough for a pathologist to confidently say, yes, this is definitely autoimmune pancreatitis. So, to actually get that positive diagnosis of AIP, the guidelines are now pointing us toward using newer, bigger core biopsy needles. These give the pathologist a much more intact piece of tissue, so they can see the structure, the architecture, that they need to make the definitive call. All right, for our third and final case file, let's dive into the complex, long-term management of chronic pancreatitis. This is really where endoscopy, especially ERCP, gets to shine as a therapeutic tool.
So here's the million-dollar question, the one you'll debate on rounds all the time. Your patient has severe, debilitating pain because their pancreatic duct is blocked by a stricture or a stone. What's the better long-term play, endoscopy or surgery? Let's see what the randomized trials tell us.
The head-to-head data is, well, it's pretty striking. When you look at pain relief 5 years down the road, surgery is the clear winner. We're talking 80% of patients getting relief with surgery, compared to only 38% in the endoscopy group.
Okay, so you're probably thinking, if the numbers are that lopsided, why would we ever choose endoscopy? And that's a great question. The answer is risk. It's a much, much less invasive procedure. So a lot of experts argue for an endoscopy-first strategy, keeping surgery in our back pocket for patients who don't get better or who aren't good candidates to begin with.
Now, for big, gnarly pancreatic stones that are causing a blockage, the treatment is often this cool 1-2 punch. First, from outside the body, ESWL uses shock waves to break the big stones into smaller pieces. Then we go in with ERCP to sweep out all those little fragments and get the duct flowing again.
And what about strictures, another major cause of pain? Well, the endoscopic approach here is also highly effective. During an ERCP, we can stretch open that narrowed area and place little plastic stents to keep the duct propped open. This can give significant pain relief to the vast majority of patients.
Okay, that was a lot of information. Let's boil this entire dense guideline down into a few crucial, high-yield takeaways that you can actually use in your day-to-day clinical practice.
Takeaway number 1. For that patient with unexplained pancreatitis, especially if they're over 40, do not stop the workup. EUS is your next step. You've got to look for that hidden cause, and most importantly, you have to rule out an underlying tumor.
Okay, this next one is a huge do not do. The guidelines are crystal clear. Do not perform ERCP for suspected type 3 sphincter of Oddi dysfunction. That's for patients who have biliary type pain but completely normal labs and imaging. A major trial proved that these invasive procedures are no better than a placebo.
And finally, let's talk safety. When you do need to perform a therapeutic ERCP, you absolutely have to be proactive. For any high-risk patient, giving rectal indomethacin and sometimes placing a temporary pancreatic duct stent can dramatically lower the risk of post-ERCP pancreatitis, which is a really serious complication.
You know, when you zoom out, you can really see the big picture here. Endoscopy has totally shifted the paradigm. We've moved away from these huge, invasive procedures to this much smarter model: diagnose gently and then treat precisely.
And that leaves us with one last big question to think about for the future, as our endoscopic toolkit keeps getting more and more advanced with crazier techniques and new devices. What's going to happen to the role of the surgeon in managing benign pancreatic disease? Is it going to shrink? It's a fascinating question that's really going to define how we care for these patients going forward.